and the funders for the program, the California Healthcare Foundation, for their support and interest in this very important area. Done a wonderful job of giving us the resources to advance this field and bring you the tool today. The further information, again, if you do need specific help, feel free to email Val Steinmetz that information, and we will be providing the recording of this program at the right after we have finished. Again, if you would like, as we proceed through the program, feel free to submit questions. We will take them through the chat room, so send them to all panelists, but we'll also be ready for calls and discussion so we can have a chance to answer your questions specifically, and we look forward to that discussion. My colleague today, Kamal Jathwani, is Corporate Manager of Research and Innovation at Center for Connected Health, has been a wonderful champion for this space for a number of years. He and his team at the Center for Connected Health have developed the ROI tool, and through their efforts we have now created this very interactive program that has been used by a number of organizations. We're looking forward through today's call to explain it to you in more detail and to actually identify those individuals and organizations who would like to use it as part of a national model. So the program was started a year and a half ago through, again, the resources from the California Healthcare Foundation with the intent of being able to find data and tools to help organizations demonstrate that they had a cost-effective program around remote patient monitoring. We moved to developing the web-based program so that it can be used personally by organizations, whether in a planning mode or more for assessment as one goes on. And if you have not yet gone on to the website for the tool, it is available at the www.telemedroi.com, and we'll continue to refer back to that as we go through the session today. The program was, the tool itself was actually tested through a number of organizations, but 5 specifically that were involved in the Center for Technology on Aging Remote Patient Monitoring Diffusion Grant Program. So we've had want to thank them again for all their efforts in that regard. We're going to present some of the results from that program as we get to the end of the session so that you can see where those organizations were in their first days of using the tool. Today we're going to start by not only giving you a background on this, but want to move very quickly into a demonstration of the tool. My colleague Kamal will walk us through how the tool works and some of the specifics about data entry. And at the end of the session, after we've taken questions and answers, we'd like to share with you some of the drivers that we've identified for positive ROI and what we have seen across a number of organizations to date. So we hope you will stay with us to go over some of those points. Again, at any point, once we've gone through the basic program, we appreciate any questions. No question is too basic in terms of how to use it, much less the potential impact. But we'll start by saying right now that we're looking for individuals and organizations who can use this tool and work with us in a national study to test its efficacy and pull together some cross-organizational information so that we can help demonstrate and move the field ahead in terms of the importance of remote patient monitoring. In terms of the original program, we did study and test the program out over a period of 6 months. We had each of the organizations that were involved in the program had a minimum of 50 individuals who were already in their remote patient monitoring program. And as you will hear, we are focusing on congestive heart failure and COPD in terms of the types of programs or patients being served. All of the programs were from throughout the U.S. Primarily the initial demonstration sites, as you'll see, were in California, but is now being used widely throughout the United States. We have found continued success beyond this, but we will share that information again at the end of the program in terms of what we saw with our original sites, but we are seeing continued evidence of the effectiveness of this tool in other organizations. To participate in the study, we are looking for organizations that are in process with their remote patient monitoring program or have used the remote patient monitoring for a period of time. We're looking for organizations that we can help work with in terms of doing an analysis within their own organization, and happy to work with you in terms of determining what type of information needs to be included in the inputs and how to best analyze the results. As you will shortly see, the tool provides an opportunity for working on different scenarios and giving you flexibility to determine options for future design and operations of the program. Finally, we're excited that we will be developing information both as case studies and ideally a paper to report out the findings from this work. So those organizations that are interested in that, we highly encourage you to talk to us as we are reviewing which organizations can participate and to what degree. And clearly we want to reinforce that we do not want the issue of concern about data from an individual organization being shared with others. So all data from the organizations that do participate in the national study, the ROI tool, we will be assuring confidentiality of their information. Just to make sure one understands the ability to be part of the program, it really does not involve a significant amount of work. We do anticipate that there will be easy sign up, as you will hear how that is done, be able to create an account on our website, that you will be able to share information after you have submitted it, and that, again, we provide already the user guide for how to go through the tool and are available to provide assistance if necessary. We do want to have organizations that are going to use this in a very practical sense and be able to take the information to the C-suite, be able to work in their organization to share the findings, to make sure that it is effective and has appropriate information for use internally. We anticipate that the amount of time that would go into any person or organization working on this would be 1 to 2 weeks maximum, and depending on the availability of the data that you already have, it can be done relatively quickly. With that, I am going to turn the program over to our colleague, Kamal Jaswani, the developer of the program, who will take us through how you use the tool and some of the specific functions within it. Kamal, please.
Great. Thank you so much, David, and thank you everyone for joining us today. As David said, we're hoping that not only would you use this tool for your own education and analysis, but also sort of join us in our national effort to study this tool, its efficacy, and its ability to help you create evidence for scaling your program. Before I get into the specifics, I just want to sort of reiterate a couple things that David mentioned. The first thing is that this tool is going to be useful for people of who have programs of different kinds at different stages. It could be for people who have a small pilot right now and they're wondering about how to scale it. It could be for people who don't even have a pilot today and are wondering how to go about even starting a pilot or even think about a program. Or it could be for people who are already on their way to scale but are looking to make their program more efficient and also looking to create evidence to sort of justify their financial inputs into the program or their effort. Although we need you to at least have 50 patients in your program to be part of the pilot, you can still use the tool even if you don't. So the slide shows you about 7 steps total that you are going to go through, and we're going to go through these with screenshots. We're going to start off with looking at patient enrollments and your growth assumptions. We're going to go on over to technology costs, staffing requirements, operational costs. Step 5 then consists of outcomes, and the way we've designed our outcomes is we're focusing mainly on healthcare utilization, not necessarily quality, because we think in COPD and CHF, utilization is a really good indicator of quality of care. Step number 6 and 7 are more sort of summary slides that we hope you'll be able to use to take to your CFOs and to visually see how you're doing. And then your step 7 is sensitivity, where we're going to show you how to think about improving program efficiencies and changing your assumptions about your program. So I'm going to figure out how to move these slides. But all right, so we're going to before we start off, we have a case study, and I think this case study will really help us understand the inputs and the outcomes in the program, and it'll help you sort of benchmark your program against this. So the case study we've chosen to talk about today is Centura Health at Home. Centura has a pretty typical health at home remote monitoring program. It combines a call center, which has a traditional RN, and she leads the remote monitoring for COPD, CHF, and even diabetes. The duration of the program is on an average 1.5 months. They receive 2 or 3 nursing home visits, and they receive calls from the nursing staff as appropriate. This analysis is based on 87 patients, and what we've done is we've looked at their data before joining the program and their data after, so it's a pre and post analysis, and we've looked at hospitalization and requirement for nursing visits as our outcomes for utilization. So this is how the tool looks when you first land onto it. So there is, before you start off, you can download a manual that sort of walks you through the tool pretty much the way I'm walking you through the tool right now. It then leads you to the first screen, which is patient enrollment. So typically what happens is, now looking at the use case of you having pilot data already and thinking about how to scale it, what we would have you do is enter your number of patients in the initial enrollment window, and and then you have intervention months. So the initial enrollment will, for example, if you have 87 patients in your pilot, would be 87, and then the intervention months will be 1.5. Your 5-year enrollment goal is an interesting column where I think we've had to walk people through this and talk to them a little bit about how to calculate that or how to think about that. But typically what that would be based on is sort of the total number of patients you have in your system, the total number you think you're going to reach at scale. So for example, in our system at Partners, we have about 3,000 to 4,000 patients who are eligible for this program, and we define scale as 3,000. So, if we're able to reach 75% patients at all times, we would define that at scale. So you can look at your own system and you can think about what that means for you, and you can put that number in there. When you press the calculate button, it's going to basically take you from your initial enrollment, which is year 1, to your final enrollment, which is year 5, and divide that equally over the years and sort of give you a ramp-up period. The other thing that this screen does is it sort of takes your intervention months and it breaks out your enrollment numbers based on those intervention months and tells you how many concurrent patients you will have at any given time. This number is really useful in thinking about sort of how many devices you need at any given time, how many of these can be recycled over time. So for example, even in year 5 in this example, we have 7,500 patients, but it's only 930 patients concurrently enrolled. So that sort of dictates your technology needs and your staffing needs. We can pause after every screen if you have questions, or we can do this at the end, but feel free to use the chat function to add questions, and I'll try to answer them as we go. The second screen sort of walks you through a little bit of what your technology use is going to be. So the way we've divided up the technology is one-time technology costs and recurring costs. One-time costs are usually hardware costs and integration costs and other things like that. And recurring costs are more sort of your variable costs per person that are either per person per month or per person one time. So examples for hardware costs would be you're buying devices, or you're spending $20,000 to $30,000 on integration with your EMR, versus your recurring costs are going to be things like data, your server hosting, your miscellaneous refurbishing fees and things like that. You can put the cost, the total cost, or you can put the cost per patient per month, and then you can sort of, in the classification, use a drop-down feature to indicate whether this is per month, per patient per month, per patient per year, whatever that is, and we have multiple options on that. For the hardware, for the fixed costs that we have here, there's also a function to amortize it. So for example, if you have integration costs, you can decide whether you want to amortize it over 5 years, or you want to keep it within the first year in your accounting. And that feature is usually used to decide how you want to, whether this is capitalized or it's coming from our operating budget. The next screen basically will walk you through your staffing needs. Now, this is really important when you're thinking about scale, because a lot of times during the pilot phase, some people will staff their programs very intensively. They'll have a medical director and a research director and a telehealth manager and other things. And usually when this goes to scale, for some sites that reduces, but for some sites it goes up. And that's something that you want to think about when you're making your inputs in this. And that's going to be your fixed staffing, which is more sort of the management style of positions. The variable staffing is usually clinical monitoring resources, as well as technical support, or people who are going to consent patients, or whatever else you have required in the program. Out here, what we've done is we've come up with a patient load concept, which is basically how many patients can this resource handle per person. And in this example, we have the clinical monitoring nurse handling about 100 patients per person, and this again varies from site to site on how they want to do it and how they want to load up their resources. But the function of this is that as soon as you enter that number and we see your concurrent patient number going above that, we'll automatically make adjustments and assume that you're going to have to hire up, and that'll go into the assumption of what it costs you to run your program. So, and then this is a screen basically that has all of these other, it has other assumptions or other costs that you could incur while running your program. Typical examples of these are things like, if you're buying monitoring resources instead of having your own clinical monitoring, it will usually go in this. And in the drop-down menu under types, we'll have a few examples here for you to consider. So now going into outcomes. As I've said previously, we're assuming these are all going to be utilization outcomes. So we're thinking about utilization in the form of all inpatient hospitalizations, 30-day inpatient hospitalizations, nursing visits, and outpatient costs. Those are typically the 4 things that we're thinking about. In this example for Centura, we only had inpatient hospitalizations and nursing visits available to us, which is fine. Then we pre-populate these with national numbers for average cost, and you can easily type your own cost into the boxes if you have them. If not, we'll just assume the national numbers and give you an indication of what that means. Again, the way you input these data points could be, you could choose in between a few different types. You could do number of events per patient, or you could do percentage change. And either of them would work depending on what kind of data you have and what kind of analysis you've done on your data. And then the last column there is risk holder, and this is really important in thinking about sort of where your savings are accruing. So for example, 30-day readmissions are usually paid by the hospital, and so your risk holder will be the hospital, but all other admissions would probably be at the payer level, and so your risk holder would be the payer. In this particular example, the nursing visits were accrued. The savings for the nursing visit were accruing at the home care nurse level, and so we had home care as the risk holder. Again, you hit calculate. It'll take all your assumptions, give you a total return per patient. Visually you can make sure that it makes sense, and then sort of, if that's okay, then move ahead to the next screen. So this screen here, basically, it's a cost summary on the left-hand side and savings summary on the right-hand side. It basically will just, take it to what at a higher level and give you an assumption, and give you a summary of what the total costs were each year. And then again, you can look at that and make sure that it all looks okay. On the savings summary screen, what we have is we've divided your savings by risk holder. So in this particular example, you can see that the savings are almost equally divided between the hospital and the home care nurse. If you have other risk holders like provider group or payer or other, you'll see those lines appear on the graph as well. So this gives you an indication of where the savings are accruing and who probably should be the party responsible for scaling this program, or who's the beneficiary of this program. And this is usually very important in again, justifying this program to various stakeholders. We've had groups that go back to the hospital and show this and say, this is how it's saving, and maybe because it's so beneficial to you, you want to think about scaling this, versus maybe going to the payer and making that same argument. Then this is your sort of final ROI summary screen. This basically, takes your total cost, total return, puts it in a formula, gives you an ROI number per year and a graph that sort of shows whether your ROI is moving in the right direction or not. Typically what we'll see is, we'll see the year one ROI pretty low because a lot of the fixed costs get accrued in the first year, and your sample size is pretty small because you're still learning and you still haven't been able to enroll as many patients. And so we see a low number in year one, but over time, assuming that your assumptions are correct and that, you're going to be able to scale as appropriate or as planned, your ROI number would go up. So finally, we have a sensitivity analysis. And what this does, basically, it's really a tool for you to test out the sensitivity of your assumptions, right? So we have all the amounts from year 5 fed into the column here in the amount column. And basically what you can do is you can increase or decrease any of those numbers by up to 100% up or down to basically see the impact of that change on your ROI. So for example, if you say, okay, if I scale this to not to 7,500 patients, but to 3,000 patients, and you can, or to 30, 40% less, how's that going to impact my ROI? Is my ROI sensitive to the number of patients I enroll? Or is my ROI sensitive to the kind of technology I choose? So for example, if you're competing, if you're deciding between 2 different technology stacks and they're maybe, 20 to 30% different in cost, you can use this assumption layer here to slide it down to 30% and see whether that is, that's going to cause a change in your ROI or not. And a lot of times you'll see that maybe the one thing that you're struggling with a lot, maybe you're working really hard on negotiating technology costs, and if you use the scaler, you might realize that it's not that sensitive at all. And the biggest sensitivity is in your staffing cost, and that's when you want to think a little bit harder about how you plan your program and how you plan your staffing, and not focus so much of your energy on your technology. And that's just an example. I'm not saying that's what we see, but this tool, this page here, will help you sort of vet all your assumptions and think about where the sensitivities lie. So I think we had a lot of data here. So if there's any questions, please feel free to use the chat function now, and maybe I'll give it a couple minutes for people to type in their questions if there are any, before we move much further ahead. All right, seems like I was perfectly clear. Great. David, I'm going to try to pass the ball to you for the rest of the slides.
Perfect, Kamal. Thank you very much. And we have, besides giving you some more examples, not only of Centura, we do want to cover a few of the other programs that we worked with, and we do have a few other key elements about using the tool. But at this point, as we continue, do not hesitate to send anything in through the chat room or interrupt with questions, because we are looking forward to making sure that it is clear and easily functional in terms of getting on the actual website. So The slide that you have before you at this point shows our initial work with 5 organizations that ranged from public and private organizations, large health systems, or large home health agency. And again, the model from Centura, which, as you heard, focused on 3 different chronic diseases, had some very positive findings. Their results of using RPM, most of the savings were due, as you can see, to some of the savings to the RN visit reduction, but they also were able to see very definitive cost savings from the way they introduced technology and ramped it up. Again, a very brief intervention only over a month and a half. The other programs, such as Dignity, had a longer ramp-up time and a much more intensive program. So in their first year, had below a 1.0 ROI, which means it was not paying for the cost of the program. Yet even in that year, they had significant savings of over almost $10,000 per patient. And as they moved into the second year, the ROI, we already have that data, had moved to a positive as they were able to get more cost efficiencies and get over the initial costs of their hardware. Healthcare Partners, a large physician group in Southern California, had the greatest ROI, not only as they moved into year 2, even though it started at a low number, 1.3, but project out a significant ROI over 5 years. And a great deal of that is because their technology was an interactive voice response program over the phone, which obviously requires less hardware and development time and very modest costs on an ongoing basis. Sharp Healthcare, a large health system in Southern California, also demonstrated a sound ROI, and even though it looks steady over time, they have already implemented this and are growing it system-wide because they are getting benefits since they do have certain patient populations they're responsible for. The only organization that we're working with from the VA had a much less robust ROI, as you can see. In fact, it did not have one, but that was primarily due to putting their program in place through a randomized trial, which had significant additional costs. We're moving ahead on their program now on a regular clinic basis, which does change the way your ROI would be calculated. And just going back briefly to the information in terms of clarifying a few points from Kamal's excellent review of how you use the program, we do just want to make sure that you understand the obvious, that you do have to have access to the full clinical and financial data related to remote patient monitoring to be able to do this, so to really use the tool effectively. So we have always encouraged individuals and organizations to use this, that right out of the gate that one needs to confirm how accessible that data is, and again, what they will be, how easy it will be to get information that does function within the tool. Most organizations have found it to be not a challenge at all, but sometimes time-consuming to get that information from their colleagues. It's also important to understand the type of program you're putting in place. As Kamal nicely stated, in many cases it's not really the technology that are the high cost issues, it's really the type of intervention that you're doing, its duration, and the staffing requirements, particularly over time. We found that most of the remote patient monitoring interventions that have been tested through this tool have been in the range of 1.5 or 2 months up to 6 months. Few cases people have continued, or organizations do have full year interventions, but the majority are shorter term in terms of getting the impact that they want with their patients. In terms of equipment costs, Kamal gave you a good overview of the variation, what you can put in there, and we do always encourage those organizations that are looking at this from the beginning to do a very thoughtful analysis with the vendors they're working with to determine whether rental or lease is the way to go versus actually some other form of obtaining the hardware can have a strong impact from the technology side in terms of the ROI. And finally, just a few quick pointers. Our benchmark data were pulled from a number of national studies so that they do reflect a national average, may not your specific region, but again, are a standard national level, and just a simple guide in terms of being aware that you do not need to use commas as you enter data into this system. Before we go on and talk about some of the characteristics that we've seen and identified in terms of a positive return on investment, and point out some of our observations and some of the issues and recommendations we'd have, we'd like to again be very open to questions. And the first one is that from, as I've already addressed, the length of our various patients' lengths of time for the intervention. In the programs we had, they did vary from the 1.5 months to 1 year, but the question is, what occurs for patients that remain in telemanagement for longer years, so, or more than 1 year, as in some cases may be the case for your specific intervention. The program is sensitive to being able to address that. We do, I say that, but even though we do have it only up to 12 months, we can work with you to take a look at that. But since we're looking at the majority of programs being in that range, the primary data, it gives you just the annual length of time for using the intervention at this point. Again, that should be based on, we know it's very specific for those organizations that have been engaged in it in conducting remote patient monitoring over a number of years, but we've again found that most of those organizations moving into this who have been starting their programs and using the tool, it's been on the shorter period. Again, we will look for additional information, and we have a point that I'll turn to Kamal in terms of salary, a question regarding salary cost, in terms of whether it's loaded and whether or not the information accounts for benefits and other indirect costs. Kamal, could you answer that question in terms of how one calculates the cost for staff?
So the way we have it, you can enter, in the instructions we ask you to enter the loaded cost, not the base salary. So because the loading varies so much by institution and state that I think making assumptions about that would be hard. So we just encourage you to add the loading already to your base salary and enter that final number.
And Kamal, another question in terms of a little greater explanation about how the cost of utilization is accounted for. Please address that.
Yeah. So I was assuming that you mean hospital utilization costs, and the way we have set it up right now is that you can either use national Medicare averages, which we have already built into the system, if you don't enter any number, or if you have your own costs, you can actually put that number in, and we'll consider those costs while calculating utilization. I think that was the question, but if not, please, I'm happy to clarify.
Okay, and as we now look for and wait any of your questions, just want to cover some of the findings that we've seen with programs and some other observations. And Kamal and I will share some of our own experiences working with different organizations in this regard. Obviously, as we looked at ROI and what gets you to a positive ROI, it's very critical to have an accurate assessment of the patient size and the growth assumptions that will be in your program. The tool really is not effective if you're under 50 individuals, but beyond that, it has proven to work for all the organizations we've worked with. But it's very important to analyze carefully what you think the capacity of your organization is in that regard. And similarly, for staffing requirements, there are many different mechanisms, and we've seen those that are nurse-intensive versus others that have really worked with other staff, for example, community health workers being the individuals who are going out into the home, that can adjust the costs for staffing significantly. So as Kamal was alluding to, even though we don't say that this is the only or the greatest issue in terms of a return on investment, affecting the return on investment, we do think it's critical to look at that from the get-go and be thoughtful in terms of the changes that may occur, particularly as the patient load does go up over years and the staffing required to manage both the case management load as well as the hardware load. And Kamal, if you would address some of the technology costs as you've seen it with the different programs, that would be great.
Sure. So, I mean, as we've seen across the 5 different sites and a couple other sites that we've looked at but not analyzed, I think the most common model seems to be the rental model today. It allows for a little bit more even spread of your ROI, just because you're not spending a lot of capital money in the first year and impacting your ROI negatively. So if you do have rentals, I think you end up getting more uniformly stable ROI over the years. We've also seen the growth of cellular among all the technology stacks available today, and I think older adults, minorities, younger people today, all of them, I mean, with different rates though, have less and less are able to accommodate landline-based systems, and so a lot of these systems are now utilizing cellular connections. These tend to be more expensive, and they tend to have a monthly cost associated with the data charges. So that's just something to keep in mind. Although it might impact your ROI negatively, it does increase engagement. So overall, the effect might actually be the same. And then there are some RPM technologies that do a really good job of identifying patients that need more intensive monitoring and are able to create the right alerts, so thereby reducing the amount of actual monitoring your staff needs to do. And those, again, might be a little bit more expensive, but over time, because your staff can monitor more patients per person, end up being more efficient and give you ROI gains there. One other thing that I want to mention in operational costs is a lot of people, clinics usually are not used to managing home devices. And so, a lot of things that maybe other companies are good at, we don't think about in the healthcare system. And those are things like inventory management, refurbishment, cleaning up the devices, accounting for losses, accounting for no returns, accounting for the patient leaving and never coming back with the devices, just those kinds of things. And those things are something that you want to think about and account for. We typically see 10 to 20% loss rate, and the more rural you are or the more underserved you are, maybe that number goes up. So that's just something to keep in mind and account for. And I think the last point here is value of the program measured by change in healthcare utilization, and I think that's something we've covered. If you do have other metrics to think about ROI, like changes in medication or medication refills or those kinds of things, we've seen a couple programs doing that. I think it's a little bit harder to convert that to ROI, but it's not impossible. And if you do have that in your program, we'd be happy to sort of talk offline about that and help you out with that as well.
Thanks, Kamal. Before we wrap up with some additional findings that we've seen, again, we'd like to encourage any questions. We have another one right now about ER visits or emergency department visits and whether or not they are included in the inpatient admissions section. Kamal?
Yeah, we're just including them in the inpatient. I mean, when we were doing the pilot, we had actually broken that down as a separate cost item, and it just didn't seem like people had a lot of good data on that. What we've done now for the tool is we've allowed for you to add that as an all-cause inpatient visit separately and add a different cost item to that. So you can have two columns for inpatient. One could be ED, one could not, and you could just differentiate that by the dollar amount that you're entering for that.
Perfect. So again, we're open to other questions, but just now to share with you some of the broader observations that we have seen as we've been both using the tool and from the various programs we've worked with in our the different types of organizations at the Center for Connected Health and Center for Technology and Aging have worked with over the last several years. We want to really reinforce just a few items, particularly for those of you who are starting in the area. We realize this may be common sense for those of you who have been working in the field for a period of time, but a key issue is always finding that champion within the organization. We again and again go back to looking for the person at a high enough level to create change within the organization, and not just initially getting the program started, but really staying with the remote patient monitoring program over time, because of the usual ramp-up time issues and challenges to whether it really is going to have a significant impact either on the bottom line or improvement in quality of care for the organization. Also, those organizations that have been most successful have very good approach to looking at how one can deal with change management, because remote patient monitoring does require adjustments in terms of how staff time is used, how one works within the organization in terms of really being able to have a very robust care management program. The other aspects that we've seen right from the outset that are important, and even though they continue to stay important, are very much so from the outset, and that is how you develop a training and sharing process to get staff engaged in the development and rollout of the remote patient monitoring program. We've seen several programs that have been extremely successful because they've been able to engage the staff who are going to use the technology right from the outset and get their input so that they have buy-in from right from the get-go. And of course, being very thoughtful about the patient selection process is critical, because as many programs identify very large populations that may potentially use the remote patient monitoring, but very quickly realize that it is those who may have have acute episodes, be a small subset who do have immediate needs, and that's where managing by exception really comes into play. So looking at that, what will be appropriate and what can be handled by the staff and the target for your intervention is very important. I'll re-mention again the issue around workflow processes and changing very significantly and having to be ready to move in those areas. And not to forget how one actually does deal with the fulfillment issue of technology. As Kamal nicely stated, it is something to think about very thoughtfully in terms of what that impact could be, not only on the ROI, but just in terms of the ability of the organization to manage the technology over time. And final 2 points, I wanted to share that in terms of how one rolls out a remote patient monitoring program and continues to roll it out is critical. How one reaches out to not only the individuals who will be using the remote patient monitoring equipment, but also how you communicate with physicians who will make referrals for it, how you communicate with nursing staff and the care management teams becomes instrumental in terms of a program's rapid startup and being able to successfully deploy. and that applies again to scaling and sustainability. Many of the programs that we have worked with have been very successful in moving their program up in numbers, but also to other parts of the organization, or even taking it, in the case of some health systems, to other hospitals and components of the health system very smoothly. But it does take a very thoughtful review of what those costs will be, and that's where we see the greatest use of the ROI tool in terms of taking that information back to the decision makers to show that it does either, even if not in the very short term, but in the near term, have a definite impact on the bottom line in most cases, and that really does lead to great support for sustaining a program and expanding it to different types of patients and issues. Again, we're interested at this point in your questions or observations. Comments are welcome. We'd like to keep it open for a few minutes, but we, again, I want to encourage you as we start wrapping up to get on the system and take a look at the tool. Again, the URL is right there for you to use. And we are also available to handle any questions that you may have, questions regarding participating in the national study, and or just specifically using the program for your own organization. The program, again, is free of charge. We are interested in distributing this. If you have other recommendations for who could benefit from this and how we can share information about the tool, we would appreciate it. And again, comments and suggestions are always welcome. Kamal, let me ask you if you have any final observations or points you would like to raise.
Hi. So I just wanted to make sure that we answered the question raised by Melody, which is how vendors can become part of this program. And I just want to, there's two ways, right? One is to be part of the national study, you could help us identify sites that you deploy at, and together with the site, we can work on the ROI and provide you data and feedback. Or if you have data from another site but don't want to identify the site, we can work with the identified data as well, as long as it's kind of complete, and you can be part of one of our sites as a tester site as well. Other than that, as a user of this tool, I mean, you could build in your assumptions. You can use this tool with potential sites to help them understand what is required to scale these programs or to use the technology, compare yourself to other technology providers. There's a variety of ways in which this can be used by technology providers. And you know, definitely get in touch with us through email, and we can talk more about that.
Yes, and just to add to that, we've had a number of vendors are working with their clients and directly with us at this point to do it, and we'll reinforce again that the information shared is confidential, so that it is available only as in the aggregate form as we're trying to build a broader case and improve the tool, and that vendors can use this both with their own clients, which we highly encourage, and have found from a number of organizations that that's been very valuable because it has been taken as a very objective tool, one that that organizations can use themselves. Again, we are looking at ways that we can work with organizations in that regard, and do not hesitate to call us that way. We do have another question on the control for calculating the ROI and whether, again, pre-post. And I'm not quite sure if I understand. I assume the control is whether that's related to the baseline data that we have included, and again, whether that changes or not, or it may be, as I now see, more of the utilization comparison. So, Kamal, could you address that, please?
Sure. So that's a great question. I think while developing this tool, we went back and forth a lot on sort of what the different sites are doing, and we saw a lot of them are not doing controlled analyses. So the way we've built built this on the website is two ways, right? One is you can do percentage change, which basically means that if it's a pre-post analysis, you can look at the percentage change in a paired t-test way, and then just enter the percent change, and we'll do the calculation for you. Or the other way to do it is a change in number of events per patient, and that usually is the way we would do it if you have a control in a randomized control trial. Is you would just look at the difference in the number of events in the two groups, aggregate, reduce it to a per patient number, and then put that number in there. So either way works, and the website can handle both types of analyses.
Thank you again, Kamal. And we do want to share with you before we wrap up that, again, the presentation has been recorded, so both the recording and the slides will be available. And if you have other individuals in your organization that you would like to forward that to, please do. Or you have in mind other organizations that you think we should be in contact with, please don't hesitate to let us know. We're, again, per our thanks to the California Healthcare Foundation, interested in distributing this as widely as possible. So we'd like to wrap up and thank you for your time. We're looking forward to working with many of you on using the tool. Again, we thank you, Kamal, and to the Foundation for its support, and we wish you a very good day.
Thank you.